Welcome, everyone, and thank you for joining us today for our first oncology coding break of the year. We have a little over 530 people registered for this event. We're very excited to be hosting it. We have a jam-packed 2-hour presentation on common coding errors and misinterpretations. This is an interactive presentation where you will have the opportunity to test your knowledge throughout the 2 hours. Back to my housekeeping items, there are 2 PDF documents within the handout section. One is the presentation handout and the other is the CE certificate. We recommend you download and pull up the slides to follow along, as there is a poll question early within the presentation. This presentation has been approved for 2 CEs, category A through NCRA. The CEs are available for the live event only. However, the recording will be available on our YouTube channel by the end of the month. Today's presenter is Heather Donahue. She is our educator and internship program manager for Registry Partners. She frequently presents at state and national conferences and is often requested to share her knowledge and speak to students within the HIM and cancer registry programs. She has put together an excellent and informative presentation for today. And with that, I will hand it over to you, Heather.
Okay. Well, thank you, Carrie, so very much for that. Good afternoon and Happy New Year to everyone. I don't know about everyone else, but it feels to me like we're so much further into the new year than we actually really are. But only 18 days in. So I know many of us have set some lofty personal goals and resolutions for ourselves and hopefully are sticking to them, trying to just stick it out. I just heard that the 15th is actually called the Quitters Day, which was news to me. But that doesn't matter. As registrars, we are not quitters. We can and we will do hard things always. So with that said, have you thought about your career goals for the new year? It's not too late to set goals, make plans, and put those plans into action. So I recommend that we all resolve to commit ourselves to quality in 2024. We're such an instrumental piece of the puzzle when it comes to things like patients' overall outcomes. Their survival really does depend on us getting it right every time. So researchers and epidemiologists know what's working and where more effective treatments are needed. You've already taken the first step here by committing yourself to 2 full hours of education this year, and I promise you will not regret this. The presentation, as Carrie said, is jam-packed with information to help you produce superior and clean data. So I hope you can take the slides after the presentation and put them to good use as quick reference guides for yourself. And meet your goal of superior quality data in 2024. As Carrie mentioned, this will be an interactive experience. We do have some polls to test your knowledge, which may come before or after the topic discussed. So just think about the question and then respond as quickly as possible. And as a reminder, the poll will take over kind of the screen. You might not see the question on the screen. So as Carrie said, be sure to pull up that PDF and move through those slides as I'm moving through the slides on the screen here so that you can have the question still available to you on one of your screens while you're answering the poll. And I'm sure everyone does not have all of their manuals pulled up and ready to use. We usually don't during a presentation like this. That's perfectly fine for the sake of this presentation. Just do what you know off the top of your head and answer the best you can. Now, of course, when you're abstracting, you always want to use your resources and manuals. And one last housekeeping thing here. Questions will be answered at the end of the presentation. Also very important, please make sure that you do include a slide number for all questions so I can quickly move back to that slide and answer your question. And lastly, this is really important to me. I ask that questions are limited to topics discussed during this presentation. It's, again, really important to me to provide the most accurate and up-to-date information based on manuals, standard setter guidance, and things like that. So I know that I'm answering with accuracy and I can give you a rationale and a resource to go back to. Okay, well, let's get this party started here with our first poll, testing your knowledge on nuances and complications with coding primary site for meningioma. So, a meningioma that arises in the suprasellar region of the brain near the base of the skull is assigned which topography code? Is it A, C7019 suprasellar, B, C70.0 cerebral meninges, or is it C, C71.7 brainstem? Okay, let's have a look at the answer. So the answer is B, C70.0 cerebral meninges. So suprasellar meningiomas arise from the base of the skull near the pituitary gland and the optic nerve. Tumors in this area can cause visual problems and dysfunction of the pituitary gland. So let's take a look at why these tumors are coded to C70.0 on the next slide, rather than coded to 71.9 suprasellar or 71.7 brain. So some background information on meningiomas. Meningiomas account for 37% of all CNS tumors and 50% of all benign tumors. So it's really important to get the site code correct. As far as anatomy, meningiomas arise from membranes made up of connective tissue that surround the brain and spinal cord called meninges. The cerebral meninges in the brain have 3 layers: the dura, arachnoid, and pia mater. When meninges are explicitly stated on a report, most will code the correct site code to C70.0. But the trouble does seem to come in when the report states a location in the brain. It kind of throws us off, rather than explicitly stating, meninges. So we'll take a look at the first column here. All terms listed are coded to C70.0 cerebral meninges. And we will go through these, and I'll give you some background to kind of understand the location of each area that a meningioma may possibly arise in. So intraosseous meningiomas are rare, and they account for less than 1% of all meningiomas. The solid tumor rules, page 277, section 2, note 1 states, the dural layer of the meninges contacts the endosteum of the bones of the skull within the cranial structures. The endosteum is a thin vascular membrane that covers the inner part of the bone. These meningiomas are described as extramedullary, but thought to arise from trapped arachnoid cells. Per the solid tumor rules, these meningiomas should be coded to C70.0. It could be very tempting to want to code this to the bone because they are technically inside the bone, but again, the meningioma is thought to arise from trapped arachnoid cells. And if we back up, we saw that meninges are part of the, sorry about that. Or the arachnoid is part of the cerebral meninges. Okay, I'll try not to back up too far next time so we don't lose our slide. Moving on. Okay, we have meningiomas of the sphenoid wing. These arise in the cranial meninges that covers the bony structure. Then we have carnivorous sinus. This space is located between the endosteal and meningeal layer of the dura. Meninges pass through this area, so that's meninges passing through that area. Meningioma can arise there. We have meningiomas of the tentorium. The tentorium is a fold of the dura mater that separates the cerebrum and the cerebellum and divides the cranial cavity into supra and infratentorial spaces, which you can see in the graphic to the right here. The tentorium area. The olfactory groove meningiomas, these form along the nerves that run between the brain and the nose and account for around 10% of meningiomas. This type of tumor can cause loss of smell and can grow large enough to even cause problems with the vision. The foramen magnum, these meningiomas occur in the meninges overlying the structures of the occipital bone, where the central opening or the foramen magnum admits the spinal cord. And then the posterior fossa. This is kind of the low under area of the brain where the cerebellum, pons, and the medulla are located. Next, we'll just turn our attention to column 2. We have the less common site for meningiomas, which arise in the spinal meninges. Spinal meningiomas account for about 12% of all meningiomas and 25% of all spinal tumors. They typically arise in the dura and arachnoid mater and rarely the pia mater. These meningiomas are always coded to C70.1. And now column 3 with a very important message here and some important information. C70.9 should very, very, very seldomly be used and only used when you have absolutely no information on whether the meningioma is intracranial or spinal. This code would be more so used in a non-analytic case, maybe where you have a history of meningioma noted without any previous treatment. So the patient is at your facility with active disease, but you have absolutely no idea if that was a tumor of the spinal or cranial meninges. Again, that would be really rare too. Like usually we do have some sort of indication, and most of the time these meningiomas are cranial. And last on the slide is the extremely rare intraventricular meningiomas. These meningiomas arise in the ventricles, which is where the cerebral spinal fluid is made and distributed. They account for only 0.5 to 3% of all ventricular tumors and typically cause hydrocephalus or water on the brain, and they usually do require surgery and shunting. This is the one and only time you would have a cranial meningioma that is not coded to C70.0. Instead, you're going to code these cases, these very rare meningiomas, to C71.5. You can find more primary site coding information and instructions for meningiomas in the solid tumor rules. And I did want to point out and clarify something that can be a little bit confusing with the rules. So looking at the solid tumor rules for benign CNS on page 11, we see reportable primary sites and histologies for meningiomas. If we look down to carnivorous sinus, it states, note 1, cavernous sinus is located between the endosteal and meningeal layers of the dura. There is no ICDO site code for the cavernous sinus because tumors do not arise in the sinus itself. The primary sites are the cranial nerves passing through the sinus, C72.5, or the cerebral meninges or dura, C70.0, which covers the cranial nerve. If you stop here, it could be interpreted that C72.5 is a site code that can be used for cavernous sinus meningiomas, especially if the nerves are mentioned in the report. However, if you move on to page 16 of the solid tumor rules, reportability of non-malignant cranial nerve tumors, note 2, states, neoplasms, commonly meningiomas arising in the dura meninges of an intracranial nerve, are coded to cerebral meninges C70.0. So be sure to make sure and note in your solid tumor rules, especially on page 11, I would say, that you should use C70.0 for meningiomas and not C72.5. Again, if you just look at it quickly, it can be interpreted as C72.5 being a possibility. Okay, next up for primary site is esophageal tumors. Per SEER Appendix C, there are two systems that divide the esophagus into three subsites. The first system divides the esophagus into the upper third, middle third, and lower third. The second system describes the subsites as the cervical, upper thoracic, mid-thoracic, and lower thoracic, or abdominal esophagus. The subsites for these two different systems are not identical. You want to assign the ICD-03 typography code that describes the primary site documented in the medical record. But that's not all. Besides these two systems, tumors can also be described by measurements from the incisors. So measurements are not listed in the ICD-03, and this can cause some trouble. So for that reason, I put together this table to help with coding the primary site for any of the three possible ways the location may be described. I also included this image from SEER Appendix C, but I added in blue and in purple the site codes for quick reference. So from SEER training in ICD-03, the cervical esophagus begins at the lower end of the pharynx and extends to the thoracic inlet, or the suprasternal notch. This is 18 centimeters from the incisors, and that's coded 15.0. The abdominal per SEER training is considered to be part of the lower thoracic esophagus at 32 to 40 centimeters from the incisors. The ICD-03 states an abdominal esophagus should be coded to C15.2. And thoracic, this is upper thoracic, upper 1/3, or proximal third. You might hear any of those or see any of those. This is from the thoracic inlet to the level of the tracheal bifurcation. Also 18 to 23 centimeters from the incisors, coded C15.3. Then we have the mid-thoracic or middle third of the esophagus. This is from the tracheal bifurcation midway to the GE junction, 24 to 32 centimeters, and this is coded C15.4. Then we have the lower thoracic, lower 1/3 or distal esophagus, which is midway between the tracheal bifurcation and the GE junction, including the abdominal esophagus, 32 to 40 centimeters. Now, this should be coded when it's lower thoracic, lower 1/3 distal esophagus to C 15.5. If you have a bulletin board, this would be a great slide to print and hang for a quick reference or even save to your desktop. Next, we have various sites that seem to yield the most errors when we're coding primary site. So we'll move through this table together. So for lung, the terminology can be really tricky, so you do have to pay very close attention to your reports and be sure to capture the correct terminology in your text. So hilar, hilum, hilus, or perihilar are all coded to 34.1. But when you have supra or infrahilar, which was in addition to the solid tumor rules guidance in 2023, or extending up or down the hilus, this is coded to 34.9. So you can see that can be really tricky. Those words supra, infra, or extending up or extending down the hilus would be, the NOS 34.9 code, as opposed to the specific hilar, hilum, hilus, and perihilar. I think perihilar is the question that we get the most. How do I code perihilar? And that is 34.1. For stomach, you want to make sure that you're only coding greater or lesser curve when better information is not available. So for example, if a report states that there's a tumor in the greater curve of the stomach, and another report states that the tumor is in the body, you want to code to the body, C16.2. The lateral tongue, this is important. This is not in the ICD-03 or solid tumor rules, but it is in SEER Book 2 on page 173. This does say that the lateral tongue is to be coded to C02.3. So if you get one of those cases, the lateral tongue, and you're stumped on how to code it, there you go. The pancreas, so the USNIT process, that is coded to C25.1. And then we have these interesting Krukenberg tumors. So Krukenberg tumor is a Metz disease to the ovaries. It's composed of a mucin-rich signet ring cell tumor. The most common primary site for this tumor is the stomach, but other GI sites like colorectal, appendix could be, possibility. So a few things are important to note here. The primary site should not be ovary. Usually that's where these tumors are found, but that is not the primary site. The primary site is not pinpointed, but the pathology report states that this tumor is from GI origin. You do not want to use C80.9. You want to use C26.9 GI NOS. In extremely rare circumstances, these tumors can be from a breast primary. Staining and ancillary studies, would be performed to determine the primary site. You may see, ER/PR positivity, things like that. Lobular is usually the culprit for breast, but there are reported cases of duct carcinoma also. So if breast is determined to be the primary site, you would code to C50.9. For CNS tumors stated to be in the rail or organ or aisle of rail, this is also another kind of interesting site. This also may be referred to as the insular cortex. These are assigned a primary site of C71.0. The structure, again, it's interesting. It's deep within the lateral sulcus of the brain and not really visible from the surface. So from NIH, functional imaging studies demonstrate that the insula participate in several key auditory processes, such as allocating auditory attention and tuning into novel auditory stimuli, temporal processing, phonological processing, and visual auditory integration. So people who develop these tumors in this area may start showing signs of auditory processing disorder, where information is taken in and then it kind of comes out all scrambled, which leads to trouble, with things like following direction and trouble with verbal patterns, etc. The CP angle for acoustic neuromas and schwannomas, or schwannoma. So we might be given the location of the acoustic neuroma or schwannoma, where that's arising, but we're coding the primary site to the acoustic nerve, similar to what we see with meningiomas. So the CP angle contains the acoustic nerve, and therefore any acoustic neuroma or schwannoma stated to be of the AP angle are coded to C72.4 acoustic nerve. For lymphomas, this one also gets people. Lymphomas that are conglomerate mass in the mediastinum especially, and stated to be a mediastinal mass, we should not code these masses as C38.3 mediastinum. They should be coded to the lymph nodes of that region. A common example of this is a diffuse large B-cell lymphoma. Oftentimes they are in the mediastinum. A lot of times they are very large masses in the mediastinum, and they'll just be described as that on imaging. There's a mediastinal mass. There's then a biopsy, and we'll see registrars wanting to code that lymphoma to C38.3. But again, that would be incorrect. The correct code would be C77.1, as long as there's no other lymph nodes involved, or organs for that matter. For tumors of the thyroglossal duct, this can also kind of throw us off, but that is just coded to the thyroid, C73.9. And last, in rare instances, only about 200 reported cases, there can be a mesodermal type of mature teratoma with papillary thyroid carcinoma, usually comprising most or all of the tumor arising in the ovary. This is called stroma ovari. The histology code is 9090/3, and the primary site should be C56.9. It can be very tempting to make this a thyroid primary with mets to the ovary, but that would be incorrect. And I'll tell you, I learned this lesson myself back in my New York State days when I worked for the Central Registry. I had originally made the site code C73.9 with mets to the ovary, but then after thinking about it, it kind of seemed odd to me that a thyroid carcinoma would mets to the ovary, and it's just not a typical behavior for thyroid. So it prompted me to stop and do some research. And at that time, I learned that there were only a few reported cases on record, but that these tumors were in fact arising in the ovary. So the moral of this story is, if it doesn't seem right, it probably isn't. Do your research. Okay, it's time to test your knowledge for coding breast histology. So here we have a mastectomy pathology report from the right breast upper outer quadrant with findings of invasive ductal carcinoma grade 2. Also present in the upper outer quadrant is LCIS. So we're going to code the histology. Is it A, Sequence 1 should be 8500/3, and sequence 2 should be 8520/2. Is it B, 8500/3 only, LCIS is not reportable? Or is it C, 8522/3?
Okay, the responses are slowing down, so I'm going to go ahead and close the poll.
Okay, so let's have a look at the answer. So it is C, 8522/3. So let's take a look at why this is the answer. So there was an update to the solid tumor rules in 2023 to both H15 for a single tumor and H25 for multiple tumors. This change is reflected in note 1 that says, assign behavior code 3, even when an in situ histology is mixed with an invasive histology. This aligns with the ICDO 3.2 and was vetted with specialty matter experts. Also, you don't want to ignore the LCIS when you have any combination of DCIS or invasive ductal carcinoma. Instead, you want to assign 8522/2 when you have DCIS and LCIS. And just like we just saw above here, you want to code 8522/3 when you have a mix of behaviors, such as invasive ductal carcinoma and LCIS. The update is also reflected in Table 2 on page 24. And while we're here and on the topic, I'll also point out that you don't want to get hung up on ignoring features when it comes to ductal and lobular carcinoma. Note 1 on Table 2 states that CAP uses the term invasive carcinoma with ductal and lobular features, or mixed type carcinoma, to indicate both lobular and duct are present. So when the path report states exactly that, we do use 8522/3. And we do not ignore the features. However, we do ignore features when we have ductal carcinoma with lobular features per Table 3. You can also find that note on page 19 under terms that are not equivalent. The report must state invasive carcinoma with duct and lobular features in order to use 8522/3. Otherwise, we'll be coding 8500/3, just straight duct carcinoma. This also applies when the diagnosis is carcinoma, NST, or duct carcinoma with lobular differentiation. We do not use differentiation. We do ignore that term, and we just code to 8500/3. Okay, we'll have a look at some other histology nuances. So for head and neck, for 2022 forward, P16 is equivalent to HPV. So for squamous cell, when HPV is positive, we'll code 8085/3. And when HPV is negative, we'll code 8086/3. Now looking at terms that are not equivalent, now we're going to go back to prior to 2022. So prior to 2022, P16 is not considered equivalent to HPV. 8085 and 8086 should not be used for cases with P16 testing only. So you have to just be sure to keep those things separate. Now that we're getting, into the end of 2023 and beginning of 2024 cases, hopefully we won't run into this too much. But if you do come across a missed case, or maybe you come across a non-analytic case, you do want to make sure that you're looking at your diagnosis when using those specific codes. Also, terms that are not equivalent, so squamous cell carcinoma with prominent keratization is not equivalent to keratinizing squamous cell carcinoma. So it's one that comes up a lot. Either it's questioned or might, someone might use keratinizing squamous cell carcinoma. So I'm glad that they added that clarification. And then salivary gland adenocarcinoma, 8140, is not equivalent to salivary duct carcinoma, which is 8500. So there is a distinction there as well. Other histology coding for breast. So invasive mammary carcinoma with tubular features is equivalent to just straight duct carcinoma, 8500/3. But if you have exactly tubular carcinoma, this is coded to 8211/3. Of note, though, this is a rare histology, so double check your rules and reports before using 8211/3. For colon, those of us that have been around for a few years, carcinoma and adenocarcinoma used to be listed as equivalent terms for many, many years. This did change in 2022. Previously, we would have coded intramucosal carcinomas as 8140/3 due to them being equivalent terms. Now it should be coded to 8010/3. So another really important update there. Gastrointestinal pacemaker cell tumors is equivalent to GIST. Another thing that I'll point out while we're talking about GIST really quick here is all GIST should be reported unless stated as non-malignant. And this was another major change with GIST that was implemented in 2021. For 2023 forward, cervix cases similar to head and neck with P16. So P16 can be used to determine HPV status and can be used to code HPV-associated or HPV-independent histologies. You can see the solid tumor rules for a complete listing of histologies there. And then down to lung, high-grade neuroendocrine carcinoma is now listed as a subtype of small cell carcinoma. So they're not equivalent, which is how we treated this histology in the past. So this was a 2022 update. So again, for some of those, or some of us that have been around for a bit, this is something that we used to do. We would see high-grade neuroendocrine carcinoma and code those as small cell. That is incorrect as of 2022. So we do have to be aware of this update and cognizant, when it comes time to that. We don't want to let our muscle memory kick in and code to 8041/3 unless small cell is specifically stated. Okay, it's time to test our knowledge again on coding grade. So the pathology report, patient reports to the ER with severe right-sided pain. The CT shows appendicitis. An emergent appendectomy is performed. The pathology comes back and shows there was an appendix primary with low-grade appendiceal neoplasm. No further information is provided. So code the pathological grade. Is it A, L, B, 1, or C, 9? And I just wanted to let you know, too, I did provide a grade coding table for you to reference.
Okay, I'm going to close the poll.
Okay, and we'll have a look at the answer. So the answer is B, 1. So, it looks like this is definitely a good slide to go over then. Okay, the answer is this is coded to B1. So appendix has some default grades. So AJCC version 9, page 16 and 20 states by WHO grading definitions, all lambs are grade 1, well differentiated, and all hams are grade 2, or moderately differentiated. So I provided a cancer forum link. Let me set up for you. That discusses this, and you can check that out. Unfortunately, this did not make the 2024 updates, but it will be included in the 2025 updates, and we should implement these default grades now. So we'll continue on with grade, taking a look at some of the foundational or general rules, which can cause some errors if you aren't fully aware of how various scenarios are handled. So first up, you never want to take grade from a met site. Grade should always come from the primary tumor. Now, if a tumor extends to another organ and the biopsy comes from the organ the tumor extended to, the grade can be used since the tissue is obtained, from the primary site still. It's just grown to extend to a nearby organ. So this can be tricky since sometimes the operative report or path report might state the organ where the biopsy actually took place, and where they obtain that tissue, but you just have to pay close attention to whether the site biopsied is a continuation of tumor from the primary site or a discontinuous. met. Next, most sites, but not all, have an AJCC recommended grade system, which can be found in the AJCC chapters. If multiple grades are given, you always want to use the grade from the recommended grade system and not a generic grade. An example of this would be breast with Nottingham grade as the recommended grade system. If multiple biopsies are performed and one states something like poorly diff and the other states Nottingham or combined grade 3, you're going to use code 3 over the generic code C for poorly diff. The priority for AJCC recommended grade system is always 1 through 4 over A through D. If there is no recommended grade system, but multiple grades are given, code the highest grade. So we have a tonsil example here. There is no AJCC recommended grade system for P16 positive oropharyngeal cancers. So we'll use code C from the generic grade system for poorly diff. You want to know only A through D or 9 codes are applicable. So when you have a generic grade. So if you had a case where there was no preferred grade system and you were only given grade 2, you would use code B versus code 2 because differentiation can be described using a 2 or 3 grade system. You would go back to the generic table and see that that code B would be applicable. And last, requested consults take precedence over original biopsy results. So here are the AJCC recommended grade systems with definitions as well as generic grade system codes and a table that includes sites with no AJCC recommended grade system. So this is put together as a quick reference and is valid as of today. To reiterate, if there is an AJCC recommended grade system given, you're going to use that grade. If there's an AJCC recommended grade system, but that grade system was not used and a generic grade system was used, then you'll code the generic grade. I also looked through the AJCC chapters in version 9 protocols, and it looks like there is no recommended grade system for all of the chapters listed in the last table on the far right of the slide. So you will use generic grade system for all tumors of these sites and chapters. Another important note here is that cases that are not eligible for staging are still assigned a grade. We have to remember to keep the rules separate. So what the rules are for staging are not the rules for grade. So for example, a non-small cell lung cancer that's not eligible for AJCC staging is still eligible for grade coding, and grade can and should still be assigned. Okay, path grade also seems to give us some trouble, so let's take a look at those general rules. When it comes to behavior, when clinical and pathologic behavior is the same and clinical grade is highest, you're going to use the clinical grade. I didn't use this example on the slide here, but I do want to give it anyway. This is kind of like a late thought, but I don't know why, but we see a lot of errors with this rule when it comes to prostate. So for example, if a biopsy shows cores with a Gleason score of 4 plus 4 is 8, grade group 4, and the prostatectomy shows Gleason 3 plus 4 is 7, grade 2, both the clinical and path grade should be coded to 4. But for whatever reason, a lot of registrars want to assign the path grade right from the surgical path report, ignoring the higher clinical grade, which would not agree with the rules here and could also possibly change your AJCC stage group since grade is part of the one of the prognostic factors for assigning grade for prostate. So you do want to be careful of that and be very mindful of this rule. Next is when clinical is invasive and the pathologic is in situ. So use the clinical or invasive grade pathologically. This is another error that we do see quite a bit. Again, registrars tend to want to code the in situ grade, but the rules tell us not to do that. We take everything from the clinical time frame and apply it pathologically. Surgical resection. These two areas also seem to get registrars. So when no grade is given on pathology report or there's no residual carcinoma, we do use the clinical grade. We do not want to code 9 there. Again, we're taking everything from the clinical time frame and applying it pathologically. And last, this is definitely an area that seems to be overlooked quite a bit. When there is a biopsy of the primary site with no surgical resection of the primary tumor, but there is positive microscopic confirmation of distant mets, you want to use the clinical grade from the primary tumor and apply that pathologically as well. This follows AJCC's rule for path-confirmed mets and path staging. So these cases are considered to have met the criteria for both path staging and path grade assignment. So be sure to assign your path grade here. And now for some site-specific grade coding errors, starting with CNS. For CNS, WHO grade uses a grading schema that's based on a malignancy scale rather than a histologic grading system that can be applied equally to all tumors. WHO grade is based on studies of natural history rather than the expected clinical course following therapy. You can see AJCC version 9 protocol pages 19 through 22 for more information on that. These tumors are without exception always the grade listed in the table in AJCC as well as the solid tumor rules. One of the most common CNS histologies that we code is meningiomas, so I provided this table here as an example. For any histology listed in the AJCC version 9 and solid tumor rules, clinical grade should never be 9. Follow the table and assign the grade based on histology. This is true whether there's been histologic confirmation or not. So if you have imaging that states that there's a meningioma present, you're going to code clinical grade as 1, even when there's no biopsy performed. Now, coding pathologic grade is dependent on surgical resection being performed. So if there was no surgical resection, then you're going to assign grade 9. If there was a surgical resection and the pathology states, let's say anaplastic meningioma, but does not give the WHO grade, assign code 3 based on the table. And here we have some other grade coding errors. Again, you want to be sure and keep this slide on hand. This will help you with some of these nuances for the various sites here. So for kidney, Furman grade is no longer valid, and we want to only record the ISUP grade. Starting to see Furman grade used phasing out, so that's good, and we are seeing that ISUP grade is it has been documented. For breast, combined Nottingham grade is used for invasive tumors only, and for in situ tumors, nuclear grade is used only. For prostate, we want to be careful of Gleason score 7. So pattern 3+4 is grade 2, but pattern 4+3 is grade 3. Also important of note, CHIRP and simple prostatectomy. This is usually we see the error coming here. So a simple prostatectomy does not qualify for path staging and therefore does not qualify for path grade either. Our reason being, they don't remove the entire capsule. So AJCC says that staging requirements have not been met, and the grade rules agree with that. For corpus carcinoma and carcinosarcoma, cervix sarcoma, and corpus sarcoma. For grade coding manual, page 117, the following histologies must be assigned a grade 3 or code 3. Serous, clear cell, undifferentiated, dedifferentiated carcinomas, carcinosarcomas, and mixed mesodermal tumors or mixed Müllerian tumors. They are high risk, and so always high grade for those histologies, and the schema is 3. For ovary, fallopian tube, and primary peritoneal, for all of the histologies listed in column 2, you want to use L or H when stated as low grade or high grade. Do not use 1 for low grade and 3 for high grade. If grade isn't given, you'll assign a grade 9. But you do want to take caution before assigning a grade 9. The CAP protocol does have a checkbox for high or low grade on these histologies, so always double check that the grade is not there before assigning a grade 9. For bladder, urothelial carcinomas use L, H, or 9 only, but adenocarcinoma and squamous cell carcinoma uses 1 through 3 or 9 only. So we usually do see the urothelial carcinomas. I think that we all kind of have that, again, muscle memory of L and H or urothelial carcinomas, but be careful when you do have those more rare adeno or squamous cell carcinomas. They should never be assigned an L or an H. They should be assigned a grade 1 through 3. For colon, well differentiated through undifferentiated use grade codes 1 through 4 and not A through D. So be careful with that. If you get a case where you have, poorly diff or mod diff carcinoma, you don't want to use the generic grade codes. You want to make sure that you're looking to see that well diff equals 1, mod diff equals 2, etc. For sarcomas, this is really tricky. Low grade is coded to 1, but high grade is coded to H. So that's something that I also have hanging on my bulletin board in front of me so that I can just look up and know that. I know that there is, nuance with grade with sarcoma. Can't always remember exactly what that nuance is, so I have it right in front of me. For anus, AJCC version 9, page 16 states, all small cell and large cell neuroendocrine carcinomas should be assigned grade 3 as they are high grade tumors. So this is another example of a default grade that should be coded. I also wanted to include this question on breast grade coding that was posted in the Cancer Forum. So the question was, when assigning grade, can the values L, M, and H be used for invasive tumors? What about codes 1, 2, and 3? Can they be assigned to in situ tumors for breast? In a nutshell, the response was codes L, M, H should never be used for invasive tumors, and codes 1, 2, 3 should never be used for in situ tumors. Jennifer Rule states that this can be applied for cases 2020 or 2018 forward. They are not requiring registrars to go back to cases and make updates, although you can if time permits. She also adds that hard edits will be applied for 2025 forward, and that logic will agree with the above coding. You can also look for the update in the 2025 manual. Okay, time again to test your knowledge on coding grades. So this will be testing what you just learned. So on 12/1/23, there was a colon biopsy, colonic adenocarcinoma, poorly diff. On 12/5/23, there was a liver biopsy that showed mets adenocarcinoma from a colon primary. So we're going to code the clinical and path grade. So is it A, clinical grade 3, path grade 9, B, clinical grade C, path grade 9, or C, clinical grade 3, path grade 3?
Okay, I'm going to go ahead and close the poll.
Okay, let's have a look at the answer. And the answer is clinical grade 3, path grade 3. So that's C. You can't really see. It looks like maybe a little bit over 50% answered that. So that's great. Let's take a look here. So again, the grade coding manual version 3.1, page 29 here, states that the colon does have an AJCC preferred grade table. So we'll use codes 1 through 4 over generic codes A through D. And poorly diff for colon is coded to grade 3. We'll want to use the clinical grade when surgical resection of the primary tumor has not been done, but there is positive confirmation of distant mets during the clinical time frame, and we want to apply that clinical grade pathologically in the path grade field. So again, this follows the AJCC path confirmed METS rule. Okay, let's take a look at various needles and why it's important to pay close attention when deciding whether or not to code a surgical diagnostic staging procedure. So in order to code this field, tissue from the primary site must be removed and positive. So core needles are usually 14 to 16 gauge in obtained tissue. Fine needles are typically 25 to 27 gauge and usually only obtain cells. On occasion, a larger gauge fine needle might obtain some tissue and should be coded as a staging procedure when that happens. What I'm seeing more and more of is this newer technology that we'll see here to the right. This is called fine needle due to its gauge size of 22. But there are different companies that put out these 22 gauge needles that are mostly used for things like an EUS procedure and obtaining biopsies. So, lung, liver, pancreas, and other GI sites, especially, you want to, be on the lookout for this. These needles do obtain tissue and should be coded as a staging procedure. So look for things like shark core, fork tip, acquire, or a 22 gauge needle, and then review the path report to determine if tissue was obtained. So several studies indicate that 99% of the time, tissue is in fact obtained when these needles are used. So what can catch you is really just flipping and seeing fine needle terminology and assuming this is cytology only, especially on a path report. If you open up a path report and it says fine needle aspiration, whatever, and then followed, you can see in the gross description that there was actually tissue obtained, and they're reporting on the tissue and not just on cells, then that should be coded as a surgical and diagnostic staging procedure. You don't want to omit that. Okay, let's test your knowledge on coding lymphovascular invasion. There was a prostatectomy with adenocarcinoma, Gleason primary pattern 4, secondary pattern 3. The tumor invades the right seminal vesicle. There's angio-lymphatic invasion present, and there's perineural invasion absent. So we want to code the LVI. Is it A, 1, lymphovascular invasion present, B, 2, lymphatic and small vessel invasion only, L, or lymphatic invasion only, 3, venous large vessel invasion only, V, or angio invasion, or D, or both lymphatic and small vessel and venous large vessel invasion, or both lymphatic and angio invasion.
Okay, it's starting to slow down. I'm going to close the poll and share the results. Ooh, this was a good one. 49% said, yeah, okay.
Oh yeah, go ahead, Carrie. You can read it off.
49% said 1, code 1, 8% code 2, 28% code 3, and 15% code 4.
Okay. So let's take a look at the answer. So it is A, lymphovascular invasion present. And let's take a look at why here. So this is per SEER Program Coding Manual 2024, page 141. They do list off all of the synonyms for lymphovascular invasion code 1, and angio-lymphatic invasion is part of those synonyms that should be used for code 1. So we definitely want to be aware of and familiar of all of those synonyms for LVI. So blood vessel invasion, lymphovascular emboli, lymphatic invasion, vascular invasion, or lymphovascular space invasion even. Another one that we see coded incorrectly would be when there's ambiguous terms. So we need to be careful not to apply our ambiguous term rules to the coding rules for LVI. So for example, when the path report states suspicious for LVI, we want to code 9 per store. We want to use code 9 when it's not possible to determine whether LVI is present, and SEER also states to use code 9 when ambiguous terms are listed. So be careful with that. Also pay close attention to special circumstances for coding LVI. So for example, the CAP protocol criteria looks for small and large vessel invasion. So small vessel invasion L is coded 2, large vessel invasion V is coded 3, and if both are present, we code 4. We also have special coding for thyroid and adrenal primaries. So lymphatic invasion is coded to 2, and lymphatic and angio invasion is coded to 4. Okay, we have another test your knowledge, and this time on coding breast SSDIs. So we have a breast biopsy, invasive ductal carcinoma with ER 70 to 100% positive. So go ahead and give a go at coding the ER percent positive, and you can use the table provided on the slide. So is it A, XX9, B, R70, C, R80, or D, R99?
I am going to go ahead and close the poll. This was a good one. We do a 28%. Yeah, XX9, 24% R70, 16% R80, and 32% R99.
Perfect. Great. So take a look at the answer. So it's actually A, XX9, so 28% were correct. So the rules have changed just a few times, wink, 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 since implemented in 2018. Oops, excuse me, sorry. But the latest update to coding ERPR that falls outside of the CAP protocol ranges was added for 2023. So the update was supposed to appear in the SSDI manual version 3.0, but was missed. However, it was in the changelog as well as the SEER RSA. So the new note that was added to version 3.1 states if the range is greater than 2, then code to unknown. So any range outside of the CAP protocol ranges and those R codes that we see, if it's greater than 10, then we now need to code that to XX9 unknown. So we just got the instruction on what to do if the range is greater than 10, but now we can take a look at less than or equal to 10. So when ERPR is reported outside of the listed ranges and the range is less than or equal to 10, we'll record the R code range based on the lowest number. So for example, ER 25 to 34% is outside of the normal CAP range, but we would take that lowest number of 25 and apply it to the range code that it fits within, which would be code R30 for 21 to 30%. So in summary, less than or equal to 10 outside of those CAP ranges, find the lowest number, and then find the corresponding R code and apply that code. When the range is greater than 10, code to XX9 unknown. Also, important notes here, if ERPR are reported in both a range and then an actual percentage, code the actual percentage over the range. So the actual percentage always takes priority over those R codes. An ERPR that is stated to be less than 1%, we code those as 000 negative. Okay, now let's take a look at SSDIs for CLL, SLL. We do see these SSDIs sometimes coded to unknown value when they are in fact available in the EMR. It's just really knowing where to find that. So it's really, really important to get these SSDIs correct because CLL, or the CLL portion of CLL, SLL, uses both Lugano and Rye stage. So the only way that they could come up with to capture both stages needed for CLL is to record the Lugano stage and the AJCC stage group field, and then populate SSDIs, which will then derive a RISE stage based on our input. So it's really important, again, to make sure that we're looking for this information, finding it, and populating it correctly so that we can derive a accurate RISE stage. So for lymphocytosis, we're looking for the absolute lymphocyte count, which would be in the labs under CBC with differential, or maybe dictated in a physician note. For anemia, we're looking to record the hemoglobin, which is in the labs under CBC also, or again, could be dictated. And for thrombocytopenia, we're also looking in the labs or for a dictated note to give us the platelet value. So for thrombocytopenia, we're looking for platelets. Anemia, we're looking for hemoglobin. And lymphocytosis, we're looking for the absolute lymphocyte count. For adenopathy and organomegaly, these SSDIs are based on physical exam and not imaging. The only exception is when obesity makes it impossible for the physician to palpate the organs and or lymph nodes. In that case, the CT can be used, but must be based on the physician's statement of inability to palpate due to body mass, which then needs to be clearly documented in the text. Once the case leaves your hands and it goes on to the registrars at the state, they need to see why the CT scan was used because the rules state that this should be based on a PE. So very important to document in your text, the physician statement of the inability to palpate due to body mass, and that's why you're taking the information, or the physician is taking the information from the CT. We have a pro tip here for you. So if you're using Epic, most are using Epic at this point, or if you're using another EMR that does have a chart search function, a good way for any of your cases, but for especially this, especially if there might be dictated values. So instead of, spending a ton of time digging through the chart, digging through, all the possibilities, especially if there's nothing in labs and you're really looking for a physician statement, you can go into your chart search box and type in keywords, WBC or absolute lymph or lymphocytosis or lymphocytes, platelets, liver, spleen, splenomegaly, those type of things. Even anemia, just, to see if there's anything with a statement of anemia, and then, giving a hemoglobin. This can really help you to cut back on some time. But I do warn you that the search does not read scanned records. So, this is a great starting tool, but if the patient might have had, any of those labs drawn at an outside facility, you do want to make sure that you're manually going in and looking for those records in your outside records. And last thing here, cases with a primary site coded to C77 or an organ will be coded 5NA for all RISE staging SSDIs. So that's all these SSDIs that we just took a look at. Okay, well, you know what time it is. It's again time to test your knowledge on AJCC staging. So in November 2023, there was an endometrial biopsy. There was endometrioid adenocarcinoma grade 1, followed by an MRI of the pelvis that showed mild endometrial thickening, no pelvic lymphadenopathy, and no mass. Then there was a total abdominal hysterectomy and BSO with path showing grade 1 endometrioid adenocarcinoma. It was confined to the endometrium, involving 30% of the myometrium. The bilateral ovaries, tubes, cervix were all unremarkable, and there was no LVI. So we want to assign the pathologic stage. Is it A, PT1A, PNXCM0 stage 1? Is it B, PT1A, CN0, CM0 stage 1? Or is it C, PT1A, PN0, CM0 stage 1? Or D, PT1A, PNX, CM0 stage 99?
Okay, I'm going to go ahead and close the poll. It looks like B and D were the majority, followed by A and C.
Okay, well, great. So looks like some of us might be scratching our heads on this one, wondering why the answer might be, or is actually B, PT1A, CN0, CM0, stage 1. So we can take a look at that here. The site-specific rules for path classification in AJCC, 8th edition, page 673, states, if surgical pathologic findings are insufficient, the CT, CN, C, or PM categories should be used on the basis of clinical evaluation. Since there were no lymph nodes removed, but there was an MRI prior to surgery that showed no LAD, we can apply CN0 to satisfy pathologic stage. And this was confirmed by several Cancer Forum posts. So with that said, I put together this table of sites where lymph nodes are not required to be removed or microscopically assessed in order to assign a pathologic stage. So let's take a look at some of these here. So in situ neoplasia should never be assigned a PNX or a stage 99. If lymph nodes are not removed, we assign CN0 and we come up with a stage 0. For melanoma and sarcoma, PT1 tumors can be assigned a CN0 pathologically, and you could see AJCC Chapter 1 for those examples for exceptions to lymph nodes. For ovary, nets, renal, pelvis, esophagus, and thyroid, PNX is allowable to complete pathologic staging in certain circumstances listed in the table here. For kidney, we do see this one missed a lot. T3 tumors with NX can be staged. So NX is allowable, and you do see this since many times lymph nodes are not removed with nephrectomies if they weren't suspicious, especially if they weren't suspicious on imaging, and therefore we have NX. If the tumor is T3, staging requirements are considered to be satisfied even with that NX. For thyroid, dedifferentiated thyroid cases, any N, including NX, is allowable for staging. For anaplastic histologies, NX is also allowable for T1 through T3A tumors. For GIST, nodal involvement is extremely rare, so CN0 and CN1 is allowable to complete pathologic staging. Okay, so we have another test your knowledge. So this time we're going to look at AJCC appendix staging. So let's assign the path T for a low-grade appendiceal mucinous neoplasm involving the muscularis propria. Is it A, PTIS, B, PT1, or C, PT2?
Share the results. Looks like 47% PT1, 30% PTIS, and 23% PT2.
Okay, great. So let's take a look here. So the answer is A, PTIS. So LAMs are very different from other digestive organ tumors. They have more of a pushing invasion versus an infiltrated invasion. So there is no T1 or T2 classification for LAMs. Muscularis involvement is not classified as T2 like we usually see with other digestive organs, but rather CIS. You can see AJCC version 9 appendix for more information on staging your appendix cases. Let's take a look at some other AJCC nuances that can lead to some staging errors. So for cervical lymph nodes with unknown occult primary of the head and neck, Chapter 6, there's a note that isn't really right up front and can be easily missed if you haven't read through the entire chapter. So the note on page 76 states, for all occult primaries with cervical lymph node involvement, EBV-related cervical adenopathy should be staged using Chapter 9. HPV-related cervical adenopathy should be staged using Chapter 10. And EBV and HPV unrelated cervical adenopathy should stay right in Chapter 6 for staging assignment. For larynx, overlapping tumors in the larynx should be assigned staging based on the epicenter or location of the bulk of the tumor, using the appropriate stage group table for glottis, subglottis, or supraglottis. For breast, intramammary lymph nodes are not the same as internal mammary lymph nodes. Intramammary lymph nodes are treated as axillary lymph nodes for staging purposes. And for lung, synchronous primary tumors is not the same as separate tumor nodules or intrapulmonary metastasis, which we're going to dive into on these next slides. So lung can cause a lot of anxiety and coding errors if you don't fully understand the disease patterns. So hopefully these next few slides will help to sort some of that out. So per AJCC, classification of lung cancers with multiple lesions poses some problems because the rules are sometimes ambiguous and their application may be interpreted differently in each situation. Therefore, a special subcommittee for lung cancer staging studied these issues and made recommendations for uniform classification depending on disease pattern. The subcommittee established 4 disease patterns, and we'll be looking at those a bit closer. Starting with the first here, this is probably what's more of the most common disease pattern. So lung cancers with separate tumor nodules of the same histopathologic type, aka intrapulmonary metastasis, which we are familiar with due to our SSDIs. The second disease pattern is synchronous primary tumors. This would be 2 or more primary tumors happening at the same time in the same lung that are classified separately. These 2 tumors have nothing to do with one another. They're their own individual processes. The third disease pattern is multiple adenocarcinomas with prominent ground glass features on CT and lipidic pattern on past exam. These tumors are classified by the T category with the highest T value assigned from the largest or more extensive or most extensive tumor. The last disease pattern is diffuse pneumonic type lung cancers. These cancers manifest in a regional distribution pattern and are assigned a T value based on location. So if there's a single tumor area, we assign TNM as usual based on size, nodal disease, and mass. If there are multiple areas of disease, T3 is used if the distribution is confined to one lobe, and T4 is used if additional ipsilateral lobes are involved, and also applies if there's extension into an ipsilateral lobe. Let's take a closer look at intrapulmonary metastasis. This refers to a single tumor source that is metastasized within the lung. So think of one main tumor that is broken off and traveled within the same lobe or a different ipsilateral lobe of the same lung. This is also what is referred to as separate tumor nodules that we record in our SSDIs. This diagram here depicts a single tumor with what looks like a few separate tumor nodules. So one main tumor with those few separate tumor nodules that have broken off from that main tumor. So the T category captures the presence of intrapulmonary metastasis in T3 or T4 when the nodules are in the ipsilateral lung. And the M category captures contralateral nodules. So how do we know when there are synchronous primary tumors or separate tumor nodules, aka intrapulmonary metastasis? So thankfully, as registrars, we don't really have to figure this stuff out on our own, but it's still important to understand why tumors may be classified as intrapulmonary metastasis or synchronous primary tumors when we're capturing these cases, especially when we see physician staging and things like that. We want to make sure that we're capturing the cases accurately and we're not overriding a physician staging if in fact we do have one scenario or the other. So there are both clinical and pathologic criteria that are looked at to determine if they're dealing with a single tumor source or multiple synchronous tumors. So let's start with the clinical criteria for intrapulmonary metastasis or a single tumor source. So same histology proven by biopsy of the dominant mass and or nodules, or, important here, or presumed same histology. This does not have to be, multiple biopsies and proven that they are definitely the same histology. They can just be presumed same histologies. And those, that's usually based on things like radiographic appearance, similar growth pattern on imaging. Also, they look for significant nodal or systemic metastasis. And if they do obtain biopsies from both the dominant mass and additional nodules, they're looking for similar biomarker patterns. For pathologic criteria to determine if there is intrapulmonary metastasis or a single tumor source, they're looking for separate tumor nodules to show similar or matching histologic appearance and exactly matching breaking points identified by comparative genomic hybridization. Relative arguments that favor a single tumor source to be considered with clinical features would again be same biomarker pattern and or significant nodal or systemic disease. And one last thing here on the bottom of the slide, it's important to note that multiple in situ nodules are never, ever considered intrapulmonary metastasis. This does make sense by nature of in situ tumors. They don't have any biological access to travel. Okay, now we'll have a look at synchronous primary tumors, which is characterized by at least two primary tumors that are simultaneously identified in the ipsilateral lung that have been deemed to be not intrapulmonary metastasis, not from a single tumor source. In other words, again, the patient has two primary tumors occurring at the same time that have absolutely nothing to do with one another. They're just coincidentally there at the same time. We also have clinical and pathological features that support synchronous primary tumors, which again would be unrelated to one another. So clinical features to support synchronous or second primary tumors. So one of the most straightforward and obvious would be biopsies that show clearly different histologies. So maybe one is adenocarcinoma and one is squamous cell carcinoma. Another feature that would favor synchronous tumors is different biomarker patterns. Other arguments that favor tumors to be synchronous clinically are different radiologic appearance or metabolic uptake, different growth rates, and the biggest one really is absence of nodal or systemic disease. And pathologic features to support synchronous primary tumors, again, clearly different histologic types based on comprehensive histologic assessment. Also, tumors that are squamous carcinomas that have arisen from carcinoma in situ. Other arguments that favor synchronous tumors to be considered with clinical factors, again, are those different biomarker patterns and absence of nodal or systemic metastasis. And now we'll take a look at other disease patterns and behaviors. So formerly known as bronchoalveolar carcinomas are the lipidic growth pattern cancers, which are characterized by tumor cell proliferation along intact alveolar walls without stromal or vascular invasion. These cancers with lipidic pattern are classified based on radiographic and pathologic appearance. So adenocarcinoma in situ, or AIS, on CT appears purely ground glass and sometimes might show a bubble appearance. On pathoval, they're less than or equal to 3 centimeters with purely lipidic growth patterns and no invasion. Minimally invasive adenocarcinoma, or MIA, show non-solid ground glass opacities with small solid central area on CT. The ground glass area represents the non-invasive or invasive component, and the solid component represents the invasive component. On path exam, these tumors are less than or equal to 3 centimeters and are either purely or predominantly lipidic and have less than or equal to 5 millimeters of invasion. And these are our T1MI tumors. And the invasive lipidic predominant adenocarcinomas on CT show partially solid nodules or mass and may also appear as bubble-like lucencies. On path exam, they have predominantly lipidic pattern with greater than 5 millimeters of invasion. These tumors are assigned a T value based on size or invasion. And for staging purposes, none of these histologies should be counted as separate tumor nodules. So now that we've gone through all the disease patterns, when exactly do we use the M suffix for lung cancer staging? So I put this table together to give you a good visual. So keep in mind that the M suffix denotes multiple primary tumors in a single organ. So we never use it for intrapulmonary metastasis, since this is a single tumor source with metastasis within the same lung. This also never applies to multiple in situ tumors. We do use the M suffix for minimally invasive and lymphocytic predominant adenocarcinomas. We also use the M suffix when we have multiple synchronous tumors that have nothing to do with one another, that are happening at the same time in the same lung, and our solid tumor rules lead us to abstracting a single primary. We would use the largest, most invasive and extensive tumor to assign TNM, and use the M suffix to denote that there were synchronous primary tumors, and staging is based on that most extensive tumor. Here we have some other non-disease pattern common coding errors for lung that come into play when there's standard setter disagreements. For some reason, we tend to want to follow AJCC's lead with SEER staging also. I don't know why, but it's just how it is, and they don't always agree, which is a good reminder to always reference the applicable manual for each field that you're entering. So I put this table together to help guide you through getting both your AJCC and SEER summary staging correct. So in column 1, we have the structure with direct extension. Column 2 is AJCC's value when the structure is involved. Column 3 shows that what AJCC's stage group would be if there were no METs involved. And column 4 shows what SEER summary stage would be for the structure involved. So under distant for SEER, it does state including further contiguous extension. So just keep that in mind too. When you go and if you're in thoracic chapter, you're looking at lung, you look under distant, it does say in parentheses, including further contiguous extension. This is really important to note. You don't want to code regional by direct extension just based on the tumor extending to the nearby structure. So let's take a look at some examples here. The adjacent rib and the heart and visceral peritoneum is T3 for AJCC and would result in a 3A to 3C stage if there were no METs, but SEER says the rib is distant. The inferior vena cava is T4 for AJCC, stage 3A to 3C, but SEER says that's distant. The next one is probably the most common SEER summary stage error for lung that we see when we have separate tumor nodules in a different lobe. This is T4 for AJCC and still stage 3A to 3C, but distant for SEER. So again, very, very important. Separate tumor nodules in the same lobe would be regional by direct extension for SEER, but when they're in different lobes, it's distant. Ipsilateral or same-side scaling lymph nodes are regional, and M3 for AJCC, distant for SEER. Contralateral mediastinal hilar lymph nodes are all N3 and still regional for AJCC, but SEER says no, those nodes are distant. All supraclavicular lymph nodes, again, still regional to AJCC, N3, and SEER says they're distant. So be sure to have this table handy when you're working on your lung cases as well. These lymph nodes are definitely another major source of SEER summary stage errors due to the N3 assignment in AJCC. So you don't want to have yourself a regional by direct extension and lymph node SEER summary stage if it should be distant. Okay, so we just bottom line, we have to be very cognizant of the disagreements and keep AJCC and SEER summary rules separate. Okay, we're on our last chance here to test your knowledge, and this time we're going to look at coding heme treatment. So how is CAR T cell therapy captured in the abstract? Is it A, other, B, heme transplant, C, chemotherapy, or D, immunotherapy?
The votes are slowing down, so I'm going to go ahead and close the poll. And it looks like immunotherapy is the winner, followed closely by heme and other, and then chemo.
Okay, great. Thank you. So let's take a look. The answer is D, immunotherapy. So this is a new and emerging type of therapy and very different from what we've seen in the past, really. So in CAR T-cell therapy, T-cells are collected from the patient. The T-cells are expanded by millions and re-engineered in a lab setting to fortify these cells, making them much stronger to go in and fight the cancer. Once this process is complete, the T-cells are reinfused to target B-cell antigens, CD19 and BCMA. And this treatment is currently approved for B-cell non-Hodgkin lymphomas, follicular lymphoma, mantle cell lymphoma, and multiple myeloma. Current studies on other hemes and solid tumors are underway, including pediatric and adult brain tumors, sarcomas, non-small cell lung cancers, kidney cancers, and osteosarcomas. I did come across an article. I was doing some research on this. They're really ramping up the testing on this with pediatric brain tumors, and they did see some response in the pediatric patients, but there needs to be further testing done and looking at maybe earlier immunotherapy with this CAR T-cell therapy rather than later in the disease process. So we'll be on the lookout for possibly coding this type of therapy for other sites in the future. Okay, we're going to take a look at some more heme treatments in a few minutes, but first let's take a look at some of the common radiation conundrums and errors that we come across. So of note, all information here is located in the 2024 STORE manual under radiation data items, as well as Appendix R, CTR Guide to Coding Radiation Therapy, which I'm sure will be updated to ODS Guide in the next manual release. I've also checked Cancer Forum for some clarifications just to make sure that the interpretation is correct here. So, okay, we'll start by looking at prostate. So there's been a clarification added for prostate when seminal vesicles are treated. Now, if you recall, over the last few years, we were back and forth. We do code it this way, we don't code it that way. We do code it this way, we don't code it that way. So this is important here to note that they have come up with, consensus, and this is how they want us to code various scenarios. So when the prostate and seminal vesicles are treated with the same dose at the same time, we're going to code the volume to 64. When prostate and seminal vesicles are treated at the same time, but with different doses, or when the seminal vesicles alone are targeted, we're going to use code 98 for seminal vesicles. So you can take a look at the Guide to Coding Radiation Therapy, example 22, for a good visual and more rationale in this. For lung, particularly small cell carcinoma, prophylactic cranial irradiation should be coded. Prophylactic tends to throw us off, but we are to code this. This is standard of care for high-risk patients, so small cell. And typically, again, these patients have no brain mets that are showing on imaging, but it's performed in a prophylactic setting, still coded as treatment. Cervix, primary site may be coded to either the vagina or the cervix in certain circumstances when patient has HDR. So patient with cervical cancer that had a hysterectomy followed by adjuvant radiation to the vaginal apex, the volume is coded to 72 vagina, as the vagina is being targeted. If the patient did not have a hysterectomy, the volume is 71 cervix. So you can take a look at the Guide to Coding Radiation, example 23, for a good example there, as well as the rationale. For sites excluding breast, when site is surgically removed and the surgical bed is targeted, code the volume to the primary site. Do not code to other NOS or like an unknown code. An example of this would be when the pelvis is stated as the primary target volume after a radical prostatectomy, hysterectomy, or cystectomy. The volume should be coded to the organ the cancer originated in, even if it's been removed, and the lymph nodes. For breast, IORT can be external beam or high dose HDR, brachy. So it's important to look for the method the IORT was delivered. So IORT using Zeiss Intrabeam Zoft Accent is all external beam. IORT using Savvy Mammocyte Contura MLB is HDR. The volume for both external beam and HDR is always the partial breast 41, and lymph nodes are never targeted. For external beam, the planning technique is 0-2 low energy kV photons, and the total dose is coded in CGY. For HDR, the planning technique is 88, not applicable. The total dose is coded in CGY if given, and if it's not given, we record 9999998. So be careful with that. Make note that was another clarification that came out a few years ago. So, at first we were coding all brachy total dose to 9999998. Now they're saying if there is a total dose given in CGY, we can go ahead and code that, and we should code it. For head and neck, many summaries will simply state just very NOS head and neck. We need to determine the primary site and code the volume to that site. So for example, if a patient had a squamous cell carcinoma of the base of the tongue, and the summary just states head and neck, code the volume to 22 oropharynx, because we know that they had a primary of the base of the tongue. Okay, on to some common heme treatment errors. We mostly see aspirin and phlebotomy not coded at all. Excuse me. Let me start that again. Okay. We mostly see aspirin and phlebotomy not coded at all because neither really agree with the definition of treatment. But for these blood diseases, it was decided that both aspirin and phlebotomy should be coded. Aspirin should be captured and coded as other therapy for essential thrombocythemia, or ET. Previously, we were instructed to do the same for PV, polycythemia vera, but that was found to be inaccurate. So if you are still coding aspirin for PV, you want to stop capturing that, as that's incorrect. Phlebotomy is used in polycythemia vera to remove blood until the hematocrit reaches a normal level, which can be every other day in the beginning, and then maybe weekly, followed by every few months for maintenance. This is also coded as other therapy. So you want to make sure that you're not overlooking that. Dexamethasone is used in diseases like leukemia, lymphoma, and multiple myeloma to control cellular proliferation. This is coded as hormone therapy when CRX indicates that this is a method of treatment for the disease that you're coding. And of course, we just talked about CAR T-cell therapy. So hematologic transplants, these can be tricky to code. So both a bone marrow biopsy both a bone marrow transplant and stem cell harvest are transplanting or infusing new stem cells into patients for various reasons. So first we have to understand what stem cells are, and they're immature cells from which all other cells are generated. It's pretty amazing. So they're found in the bone marrow, the bloodstream, placenta, and umbilical cords. And stem cells will mature into needed blood cells, and they kind of serve as a repair system. So a bone marrow transplant takes stem cells from the patient or matched donor and then transplants the cells to replace and regenerate with new healthy marrow. A stem cell transplant is also a procedure to replace stem cells for the renewal and repair. This is called a peripheral blood stem cell transplant, PBSCT, or usually we see it shortened to stem cell transplant, SCT. The stem cells are pushed out into the peripheral blood and then they're retrieved. So you might see the terms mobilization phase If you do, that would be an indication that this is a stem cell transplant versus bone marrow. What can be confusing is that, again, bone marrow transplants are sometimes referred to in the medical record as stem cell transplants. So everything is a stem cell transplant in the record because they are transplanting those new stem cells, but they might be from the marrow. So it's important to note where the stem cells are sourced in order to code the correct procedure. When they are sourced from the bone marrow, we code as bone marrow transplant. And if they're donor stem cells from someone other than the patient, that would be code 12, allogeneic. And if the stem cells come from the patient's own marrow, this is coded 11, autologous. When stem cells are harvested from the peripheral blood or cord blood, this is coded to 20, stem cell harvest. Okay, and finally, common coding errors with lymph node and endocrine surgeries. So starting with lymph nodes, this is an error that we see over and over and over again. So we have to remember that each field we're coding has a different set of rules. For regional lymph node biopsies, we code the procedure, whether the results were positive or negative. For STOR, scope of regional lymph node surgery, record surgical procedures which aspirate, biopsy, or remove regional lymph nodes in an effort to diagnose or stage the disease in this data item. There is no instruction to only code positive results. We code all regional biopsies, regardless of positive or negative. So if we take a look here, if we have a negative lymph node biopsy, scope of regional lymph node surgery is coded to 1. Date of regional lymph node dissection is blank. Lymph nodes positive is 0, 0, since the biopsy was negative. Lymph nodes examined is 95 to show no lymph nodes were removed, but there was a biopsy. And your CN0 will have the F suffix coded to show that there was a biopsy proving N0. Next scenario here is when sentinel lymph nodes fail to map. So sometimes there is an intention for a sentinel lymph node biopsy to happen, but they inject the dye in the patient and they fail to light up any nodes. They don't see any sentinel nodes, can't find them. When they do make that attempt, these procedures are still coded. So to determine if a sentinel lymph node biopsy was attempted, you want to look for the dye to be injected, an incision made with an expiration of the axilla. If no further axillary lymph node dissection is done, you want to leave the date sentinel lymph node biopsy blank, and this is per Cancer Forum and SEER. Sentinel lymph node positive will be 98. Sentinel lymph node examined will be 0, 0. Date regional lymph node dissection will also be blank. Regional lymph nodes positive would be 98. Examined would be 0, 0. But scope of regional lymph node surgery will be coded to 2, sentinel lymph node biopsy, because the attempt was made, and this is per STOR. And last here on this slide is a bilateral salpingo-oophorectomy as an endocrine surgery in breast cancer patients as a means to suppress hormone. So if part of the first course treatment plan was for the patient to have a BSO as part of her treatment to suppress the hormone, this should be coded, and it's coded as an endocrine procedure, code 30. The same is true for prostate. So if there is surgery to remove the testes, then you would do the same and use endocrine procedure code 30 if that was part of the treatment plan. Okay, and just when you thought I was done, we're almost there. I have some exciting news to share first. So we're really excited and pleased to announce that we have launched our new Facebook group. This is called Oncology Insights by Registry Partners. We just launched this group yesterday. We have a lot of members already. So if you've already joined, welcome. We're so glad to have you. We definitely want to encourage you to join if you haven't. This will be a space for the registrar community to find like helpful tips and resources. We'll have some fun interactive polls and other exciting things coming up. We'll post clarifications and other important announcements from the standard setters. And of course, we'll always highlight, when there's any important registry updates as well. This will be a great space for any ODSCs, for registrar kind of peer interaction. Students are also encouraged to join, those on the path to becoming an ODS. And of course, all of us that are already certified can most certainly join. You don't want to miss out. So be sure to update your settings once you are in the group so you don't miss any of our important posts. So you can just follow the instructions here. Once you join, you'll just click on the down arrow for join, and then click on the bell, manage notifications, and then you'll click on post, and then you'll just change all of your settings, or they might already be set this way. Just make sure that they are set this way so that you get your in-app notifications. You get push notifications if you want them for all the highlights, and then batch mentions. So we will definitely do some batch mentions when we have some big announcements to make. So be sure to update those settings there. Oh, also, one other thing, we have already posted our first resource that we want to share with the registry community. It's a fantastic desktop reference that can be downloaded and either saved to your desktop, or if you prefer to print, you can print the reference. It is on breast. We have a great table that's set up for all of the various lymph node scenarios that can be kind of pesky and hard to navigate when you have, lymph node or sentinel lymph node biopsy plus an axillary lymph node dissection. Is it at the same time or a different time? So we've taken all of those scenarios and put them into a table to help you code all of those fields correctly. We also have these site codes with different terminology. So sometimes we get terminology and we go to our ICDO manual and we can't find anything that falls within the site codes that we see in front of us. So all of those, all that terminology in the applicable site code is on there as well as the clock positions. That's always nice to be able to have, look at quickly and reference for your site code. All right. So with that, if there's any questions, we can take them now.